Hello, everyone. My name is Shadi Yagi. I'm a vascular neurologist at Brown University, and I'm the writing group chair of the scientific statement, Treatment and Outcome of Cervical Artery Dissection in Adults. First of all, I want to thank the American Heart Association for commissioning the scientific statement. A little background about cervical artery dissections. Carotid and vertebral artery dissection, it accounts for 2% of ischemic strokes, but up to 25% of strokes in young adults. Dissection happens because of interplay between certain genetic factors like connective tissue abnormalities, environmental factors or triggers such as infection or neck trauma, and risk factors such as low body mass index. If you want to see more details about this, we cover this in the paper. Refer to figure S1 and you'll see some more details about why cervical artery dissection happens. Studies investigating treatment approaches and outcomes of patients with cervical artery dissection, these have several limitations and some yielded conflicting results. Thus, there's a lot of equipoise in practice. In this statement, our goal was to provide guidance on the management of patients with cervical artery dissection using the current available evidence. The diagnosis of cervical artery dissection can be very challenging, particularly in patients who present to the emergency department or to outpatient clinics with non ischemic symptoms. These patients could have isolated neck pain or headache and sometimes non specific symptoms. So it's really important to consider a diagnosis of cervical artery dissection in patients who have new or worsening headache, particularly in the presence of cervical injury or manipulation, or sometimes they could have a Horner syndrome if they have a carotid dissection. The diagnosis can be made based on a CT angiography or an MR angiography, or in rare occasions, a cerebral angiography. Both MRA and CTA, they have very good sensitivity and specificity in making the diagnosis. Certain imaging signs of cervical artery dissection, and we show these in figure 1 in the paper, they include a tapering stenosis or occlusion at a typical dissection site. So typical dissection sites are the V2 or V3 segments of the vertebral artery, or 2 to 3 centimeters above the bifurcation of the carotid artery. So a tapering stenosis or occlusion is one of the imaging signs of cervical artery dissection. Intramural hematoma is another one, bleeding in the vessel wall that you can see on MR angiography. Generally, this is a hyperintense signal on fat suppressed T1 double lumen as well. You can see two lumens, the false lumen and the true lumen. You can sometimes see an intimal flap, and sometimes you can see a pseudoaneurysm. And these are all findings suggestive of a diagnosis of cervical artery dissection. Keep in mind that sometimes other conditions can mimic these imaging findings of cervical artery dissection, and certain important mimics are carotid webs, a fenestration in the artery, which is a normal variant. Certain imaging artifacts can mimic cervical artery dissection, and a pseudo-occlusion. If there's an intracranial occlusion, you can see a flame-shaped or tapering occlusion that's suggestive of more of a distal occlusion. So just when you're considering the diagnosis based on this, make sure that there's no intracranial occlusion before considering a carotid dissection diagnosis. And all these mimics, we show them in figure S2, so refer to figure S2 in the supplement for more information about this. In addition, when seeing patients with cervical artery dissection, it's important to think of underlying connective tissue disorders that could be associated with the dissection. So some of the things that could be considered are monogenetic connective tissue disorders, particularly in patients who have clinical features or family history of these conditions. And in these patients, we could consider genetic counseling and genetic testing. In addition, certain associated conditions that could imply an underlying vasculopathy include aortic root dilatation and cerebral aneurysms. So screening for these conditions could be considered. The diagnostic workup in patients with cervical artery dissection is shown in figure 2 in the manuscript. So please refer to it for more information about this. One of the Topics that's covered in the scientific statement is acute treatment in patients with cervical artery dissection. In patients who have an ischemic stroke due or are suspected to have an ischemic stroke due to cervical artery dissection, who are otherwise eligible for thrombolysis, thrombolysis should be considered in these patients. But a very careful risk benefit discussion should be considered in patients who have intracranial extension of the dissection, because this subgroup is thought to have an elevated risk of intracranial hemorrhage with thrombolysis. Um, in addition, mechanical thrombectomy with or without stenting should be considered in patients who are eligible for this treatment. Moving on to secondary prevention, which is a really important aspect of this scientific statement. In patients with cervical artery dissection, we know that the risk of ischemic stroke within 180 days is about 3.5%, but the majority of these strokes happen within the first month from diagnosis. Therefore, really diagnosing these patients early and initiating antithrombotic treatment as soon as the diagnosis is made is a really important aspect of secondary prevention. And the stroke risk in patients with cervical artery dissection increases with male sex, smoking, vertebral artery dissection as opposed to carotid artery dissection, in patients who have multiple or recurrent dissections, in patients who have high grade stenosis or occlusion at the dissection site, and in patients who have an intraluminal thrombus at the dissection site. So these several studies have shown that these are associated with a higher likelihood of ischemic stroke in the setting of cervical artery dissection. So, what do we do to lower the risk of stroke? Our general practice is to use antithrombotic treatment. And there are two classes of antithrombotic treatments that have been studied in cervical artery dissection: antiplatelets and anticoagulation. And studies comparing antiplatelets to anticoagulation in patients with cervical artery dissection, these studies yielded mixed results, thus leading to variability and equipoise in practice. I'll go over two landmark randomized trials in patients with cervical artery dissection looking at stroke prevention strategies. CADIS is the first one. CADIS enrolled patients with cervical artery dissection and randomized them to antiplatelet versus anticoagulation. CADIS showed no significant difference between the two arms in terms of bleeding and in terms of ischemic stroke risk. The other trial is TREAT-CAD. TREAT-CAD randomized patients with cervical artery dissection to aspirin versus warfarin. TREAT-CAD showed that aspirin is not non-inferior to warfarin, and there were fewer ischemic strokes in patients treated with warfarin compared to aspirin. Both studies were underpowered to detect a statistically significant difference in outcome between the two treatments. And a meta analysis that combined the two trials showed non significantly lower ischemic stroke risk with anticoagulation compared to antiplatelet. But on the other hand, it showed non significantly higher major bleeding with anticoagulation compared to antiplatelets. In this statement, we suggest that provider consider an individualized treatment approach whereby treating high-risk patients with anticoagulation if safe, if they have a small stroke, if they don't have any bleeding within in the stroke bed or concern for bleeding risk. If they're high-risk patients for ischemic stroke, it would be preferred to treat them with anticoagulation. But those who have a lower risk of ischemic stroke, it would be reasonable to treat them with antiplatelets. Also, when deemed safe, we suggest considering dual antiplatelet therapy with a loading dose instead of antiplatelet monotherapy. And this is to optimize the antithrombotic effect early on when the risk of stroke is highest, particularly in those patients who would otherwise qualify for minor stroke and TIA trials, chance and point that show the benefit of dual antiplatelet therapy over antiplatelet monotherapy. This algorithm is shown in figure 3, so please refer to figure 3 for more information about the antithrombotic treatment algorithm that we propose in patients with cervical artery dissection. Um, Generally, we would consider antithrombotic treatment for 3 to 6 months from the diagnosis, but it could be continued beyond that in patients who have an increased overall cardiovascular risk, for example, those with a history of myocardial infarction, those with atherosclerotic disease, or those who have other indications for antithrombotic treatment. These could be considered beyond the 6-month interval. On the other hand, stenting of the dissection could be considered as a secondary prevention strategy in very rare situations, those who have impaired distal blood flow and also have recurrent ischemic stroke despite optimal medical treatment. So, generally, we would treat patients with medical treatment as a first line, those who have recurrent stroke despite medical treatment and have impaired distal flow, then these could be considered for stenting. One of the topics that's covered also in the scientific statement is about the risk of recurrent dissection. This is an important question that comes up in clinical practice, often by patients asking about the risk of recurrent dissection. Luckily, the risk of recurrent dissection is low. It's about 1% per year, but this seems higher in the first few months after diagnosis. Patients who are under the age of 50 years and those with fibromuscular dysplasia have a higher risk of recurrent dissection. We would generally consider avoiding activities associated with dissection risk, any activity that would potentially increase the risk associated with neck injury, and we list some of these in the manuscript. We suggest that providers consider avoiding activities associated with dissection risk, and we list some of these activities in the manuscript. These activities are avoided for the first 6 months from section diagnosis and longer in patients with recurrent dissection or those at a high risk of recurrent dissection. Another imaging finding that's sometimes encountered in patients with cervical artery dissection is a pseudoaneurysm. Cervical artery pseudoaneurysms can be present at the time of dissection or sometimes diagnosed on follow up imaging. They rarely cause symptoms, and the risk of rupture of a cervical artery dissecting pseudoaneurysm it's extremely low, and thus most can be observed without endovascular treatment. Endovascular treatment can be considered in those with symptoms related to compression of nearby structures, such as, sometimes dissecting aneurysms in the neck can cause cranial nerve deficits, and if these are causing compressive symptoms, treatment can be considered. Mind you that this scientific statement does not discuss intracranial pseudoaneurysms, and the treatment approach for these patients is different and not covered in this scientific statement. To wrap things up, I'll cover some important takeaways from the scientific statement. The first takeaway is to consider a dissection diagnosis in patients with a new or different headache or neck pain, particularly in those patients who have a history of cervical trauma or manipulation, or if they have an associated Horner's syndrome. The second takeaway is that dissection generally happens in the setting of either a defined or an ill-defined connective tissue disorder or vasculopathy. So screening for associated conditions, for example, aortic root dilatation, cerebral aneurysms, and fibromuscular dysplasia can be considered. The third takeaway is that the use of antiplatelets or anticoagulants for 3 to 6 months is reasonable, but also individualizing treatment based on risk of ischemic stroke and bleeding can be considered in patients with cervical artery dissection. I want to thank you all for listening, and please refer to the scientific statement for more information about the content.